must congratulate all the ROSA team, especially President Rajesh Goyal, Dr. Katta, his secretary, and Arun Vesha, the president-elect, and the entire ROSA scientific team, Jansen, Dr. Solanki, and Dr. Saurabh, for organizing such a grand web-based conference. And this is our honor that I have been the part of this conference as a moderator. Today, we have the eminent faculty, Professor Dr. P.P. Kotwal. He is a retired professor from the AIMS and presently working in the Pushpapati Singhania Hospital. His main domain is upper limb reconstruction surgery, and he has a vast experience of more than plus 50 years of experience. He has done all sort of surgery which is possible on the earth on the upper limb. And may I invite Professor Kotwal sir, please say a few words on the present conference.
Okay, thank you very much. Good afternoon, everybody. I'm grateful to the team ROSACON, Dr. Rahul Katta, Dr. Jaswant Singh for giving me an opportunity to be a part of this. I was really appreciating the way this conference has been organized online. However, because many times the webinars are held and they're just 1 hour, 2 hours, and it takes a lot of effort to do that. So this is actually a really very commendable job. Congratulations.
And we have Dr. Atal Soni. He has more than 25 years of experience of trauma, and he'll speak on the fractures of distal end of the radius. And he has seen the distal end of the radius through the ASIS, and he initially probably he has operated thousands of cases of distal radius by the plasters, then K-wires and plating. So he's a vast experience. Today he is going to deliver a talk on the distal radius. So would you like to comment a few words, Dr. Atal?
Thank you, sir. Thank you for giving me time to speak on this conference, and really happy to be part of this virtual conference. Excellently, gallantly organized conference by Dr. Rahul, Dr. Jayant, and the whole ROSA team. Really congratulate them for the mammoth job and very beautifully done conference. And I'm sure if this Corona era goes on, we'll need to do this pretty frequently in future also, with a bigger, on a larger scale, probably, even larger scale.
Thank you. And Dr. Amit Vyas, probably you are not on the screen. Can you hear us now? Amit Vyas?
We join you.
He's not here. But here is Dr. Amit Mittal. Dr. Amit Mittal is a young hand surgeon. He's a reconstructive surgeon, and he used to love the nerve repairs and all sort of hand trauma and all sort of hand anomalies and sort of whatever possible. So would you like to comment a few words on this today's conference? And
yes. Thank you, Jaswant. Thanks to organizing team, and I am very fortunate to join this platform along with Kotwal sir, who is my teacher. And we always learned everything watching his videos and his lectures when I was in Delhi. I did it through St. Stephen itself there. And just let's continue with the next round with Kotwal sir. Thank you.
So now may I invite Professor Kotwal sir for his presentation. He's going to talk on the terrible triad of the elbow. And once the terrible triad was considered as a terrible triad. But I hope with the better understanding, with the better knowledge, this terrible would become simplified after this talk. So may I invite Professor Kotwal sir to share his screen and deliver his talk.
Thank you very much, sir. As I said, I'm really grateful. Now I'll speak on terrible triad elbow. This is actually an injury which is often misdiagnosed and sometimes maltreated. So I think we'll look into this. What are the terrible about it, and how can this be simplified? The term terrible triad was coined by Dr. Robert Hotchkiss in 1996. And this was the picture in 1994 when I worked with him, 93, 94 in the US. And what is the terrible triad? It consists of three things basically, as originally described. One is the dislocation elbow, second is the fracture of the coronoid, and third is the fracture of the radial head. This is how it will look on an AP view. That's the dislocation of the elbow here and the fracture in the radial head. And the coronoid fracture can be seen better on a lateral view. The mechanism of injury is fall on the outstretched hand, which causes the axial load. That the elbow is in extension, so there is a valgus strain to that, and then the forearm goes into supination. So this is actually very ultimate posterolateral instability of the elbow, which is actually a very complicated injury. And what is terrible about it? Why this term? Because it is an extremely unstable injury. There is loss of joint congruity and instability. The fracture fragments sometimes are too small. For example, either the fractures of the radial head or the fractures of the coronoid, they are difficult to repair. And the patients don't do really very well. Not all of them, but majority of them. And there is always, or maybe remains a residual instability, stiffness, and post-traumatic arthritis. The assessment is done, the patient evaluation, you have to have the assessment about the mechanism of injury to understand the injury better and the likely injuries, associated injuries may be there if it is a part of a major trauma. Soft tissue status, you can see here, sometimes you have to wait and before this settles. The radiographs are done possibly with maybe traction views. And after the initial reduction is done, a post-reduction CT, because it is advised that the elbow dislocation should be reduced as early as possible in the emergency setting itself. The operative timing, it should be as early as possible, depending upon the soft tissue conditions, but certainly during the daytime, not in the middle of the night. And pre-operative planning for the appropriate implant and the other thing strategy must be worked out. We will take one by one. The dislocation of the elbow, as said, should be reduced as early as possible. We will then discuss about the coronoid fracture and also about the radial head fractures. The coronoid fracture, the classification given is depending upon the size of the fragment. The tip is the type 1, then the less than 50% is the type 2, and then more than 50% is the type 3, which is actually unstable, and this may be very comminuted as well. But one must understand that all fractures do not occur in a coronal plane. They can occur in multiple planes as well. And therefore, there is another classification given by O'Driscoll, and this depends upon the size and location of this thing, and this is a CT-based classification. So the type 1 is the tip of the coronoid, that's the radial head. This is the coronoid. The type 2 is the anteromedial facet. This is the lateral side because you have the radial head. And then the type 3 is the base, which is actually a comminuted and little more complicated fracture. The management, as I said, is dislocation gets the priority, reduced in the emergency as far as possible. For some reason, if one is not able to reduce it, and if it is unstable, then please stop there. Do not perform repeated reductions or manipulations. Take the patient to the under anesthesia to the OT, and then go ahead and plan the treatment. The non-operative treatment is indicated, particularly in small coronoid and radial head fractures if they are not very much displaced, not involving the larger area of the articular surface and so on. And if after reduction or otherwise, if the ulnohumeral and the radiocapital joints are concentrically reduced and congruous, then they can be treated conservatively. And if the reduction is stable through a functional range of motion, about 30 to 120 degree or so, then also this is doesn't require any surgery. And if sometimes, even with all these things, the joint may be little incongruous in under 30 degree of flexion. So in that situation, immobilize the elbow in 90 degree flexion, so it will be stable there for about 3 weeks to 4 weeks till the soft tissues, they heal. The functional outcome after non-surgical treatment is not so bad. There is a study, not very recent, 2017, congruent joint after closed reduction. There is no indication for surgery. If there is no block in supination and pronation up to 60 degrees, intra-articular fragments are not there, and the free and stable joint movement is possible up to 45 degrees. So this means that if these criteria are fulfilled, then it doesn't require surgery. There is definitely a specific treatment protocol. This was a study 2004, and the patients, they studied a patient of number of 36 patients, The protocol is that fix or suture the coronoid as shown here in the picture if it is a small fragment, repair or replace the radial head, and repair the lateral collateral ligament if it may be broken, that can be assessed at the operation table itself. And if it is still unstable after doing all these things, then perhaps the MCL should be tested and the medial collateral ligament should also be repaired. And even after all this, if this is really grossly unstable injury, and then the advice is to use an hinged external fixator for about another 4 weeks till the fractures and the joint and the soft tissues are stabilized. The commonly employed approach are a few. One is the midline posterior. That's the arm. This is the elbow. That's the forearm. The patient in lateral position. This is the midline posterior. This is actually an extensile approach because from this approach itself, you can approach the medial as well as the lateral side of the elbow to reach to the other bones. There are in this region fewer cutaneous nerves, and therefore the risk of neuroma formation is less. And relatively, as compared to the lateral, this is a little better cosmetically acceptable approach. Then the other commonly used approach is the lateral approach. This is between the anconeus and the extensor carpi ulnaris. So you go through this. The only thing is that the collateral ligament lies right here, and one must protect that. Be a little careful about it. But otherwise, there is also another approach, that is the Kaplan approach. This extends between the extensor carpi digitorum and the extensor carpi radialis longus. So, and then you go to the mid of the radiocapitellar joint here, and sometimes there may be a rupture of the lateral collateral ligament. You can utilize that. That means go through the rent of the ligament, incise the anterior capsule, and you reach to the coronoid, expose that, and get hold of the coronoid for fixation. And also, once you've done that, you can come out and fix or replace the radial head as well. Then there is the entromedial approach. Medial side, you identify and protect the ulnar nerve, and then open a window between the of a coronary teres and the FCR half part, and go to the anterior capsule, excise it, and reach to the coronoid. The operative treatment, the important thing is that we work primarily on the lateral side basically and go on the medial if required. You work from outside to inside. That means you start identifying the structures from outside to inside, the lateral, collateral, common extensor, radial head fractures, and coronoid fractures. But when you stabilize them, you work in a reverse order. That means from inside to outside. Logically also, it's easy that once you opened up the deepermost structure in the coronoid, so you fix the coronoid first, repair, or then you repair the radial head, and the outermost is the lateral collateral ligament. So in that way you are facilitated in approaching or suturing all the three structures. The fractured coronoid can be treated by suture, by the antegrade screw, the retrograde screw, or by a plate fixation if it is a really comminuted type 3 type of a fracture. The radial head is fixation by a screw or a plate. And sometimes if it is comminuted, then you do a replacement of the radial head. The radial head prosthesis acts as a functional spacer, and it creates stability by increasing the radial length and restoring the valgus restraint. The excision of the radial head in the today's context is contraindicated in the setting of a complex elbow instability. This must be remembered, because the radial head is an important stabilizer of the elbow. And if it is excised in this setting, then it results into persistent instability and early post-traumatic arthritis. The coronoid, a small fragment, can be sutured in this way, taking a suture through the capsule and the fragment of the coronoid. This is the coronoid there, that's the radial head, and you are deep to that. This is the humeral condyle, and this is how you put a suture and suture the smaller fragment. A larger fragment here, this is a terrible triad. The elbow dislocation has been reduced, and there is a fracture of the coronoid and the fracture of the radial head as well. And they both have been fixed. The fracture of the radial head fixed with smaller screws, and the coronoid by an integrate screw. So you put a screw from the front to the back, and that's the check X-ray afterwards, and this is the reasonably good function afterwards. So this is another case, dislocation, a classical terrible triad, and This is the fixed with the coronoid fixed with the screws, and this is the radial head displacement replacement because there was fractures which were comminuted of the radial head. Another terrible triad: fracture of the olecranon, fracture of the coronoid, and the radial head as well. So the radial head has been replaced, the olecranon has been fixed, and the coronoid has been fixed with single screw, and this is a retrograde screw fixation for the coronoid, and that's the reasonably good function after a good physiotherapy program. And as I said, the last thing to be repaired as you come out is the lateral collateral ligament. So what you do is, if it is a fresh injury, you can suture them like that. Otherwise, if it is a little old one and the ligament cannot be approximated, then you make intraosseous tunnels between the humerus and the part of the ulna here, the lateral, and then you take a tendon graft and put it through and you can also use anchor sutures. So this is another patient, and this is the CT scan, shows a badly comminuted fracture of the radial head. So the radial head actually it was possible to fix it, and these are the anchor screws which are used to fix or repair the collateral ligament. Another example of a repair of the collateral ligament using the anchor screws and also the small screws used to fix, and this one screw is used to fix the coronoid. Sometimes you need to repair the medial collateral ligament, and this actually you get to know after repairing the radial head, repairing or fixing the coronoid, repairing the LCL. If there is still instability, which is tested fluoroscopically, and elbow is unstable from 30 to 130 degrees, then you repair an MCL. And this is on the medial side. You protect the ulnar now. This is the medial epicondyle, and take again the sutures or the palmaris longus graft to repair or reconstruct the ligament. As I said, some people would like to use the fixator, this kind of compass hinge fixator, to give additional stability. However, there are studies in which people have used primarily this external fixator, and they have reported good results without the repair of the ligaments. The post-op rehabilitation begins 2 to 5 days. The arc of motion depends upon the what was the intraoperative picture about the ligament injuries and so on. The resting sprint is used for 6 weeks, and the 9th sprint is used for 12 weeks. The recovery time after the cerebral triad is nearly 6 months. So that means the patient has to do a good therapy program and use of splints for about 3 months, and it takes about 6 months for the repair, for the recovery to take place. So in a nutshell, what is not so terrible about this injury is that the injury is isolated and the patient is cooperative. If the stable repairs have been performed or fixations have been performed about the coronoid, the radial head has been fixed or replaced, and the LCL has been repaired. The terrible thing is when the poor stability after the repairs, delayed rehabilitation. Because of any of these reasons, polytrauma, patient requires an ICU stay for a longer period, and head injuries and so on. And if there is an uncooperative patient, because a post-op physiotherapy is also a very important part of the whole therapy, whole treatment to get good results. Thank you very much for your kind attention.
Thank you, sir, for enlightening us on this talk. Here, I want to just quickly ask 1 or 2 questions. Which is the approach you take for the fixation of a coronoid from anterior to posterior? What structures you and which is the approach you choose?
Yeah, as I said, if this is because it's coronoid alone, fracture is not so common. It is a part of the cerebral triad, and generally, as I showed the pictures also, there is fracture of the radial head also, and the lateral collateral ligament as well. So you can approach from the lateral side. So as you approach from the lateral side, you can work through the gap between the radial head created by the radial head, and then go straight to the deeper into the from the lateral side. You can either remove the radial head if it is in pieces, because it is also a technique to fix the radial head if it is fixable on the table, and then put it back and fix it with a plate or screw. And or if there is it is attached to a soft tissue hinge to the main radial radius, neck of the radius, then you can deflect the radial head outside, and you can approach and go to this thing. This is one approach. The second approach can be if you can approach from the middle side also. If there is, it also requires a repair of the middle collateral ligament. If it can be assessed in the initial assessment, you can go from the middle side as well. And some people like to use the posterior approach, as I said, because on the posterior side, you can go both sides, go to the lateral also, and you can go from the middle side also. But otherwise, if it is associated with the fracture of the radial head, it is better to go from the lateral approach.
From the lateral approach. And for the wide fixation of a radius, upper end of the radius, which approach you prefer? Either you go through the ECU, EDC gap or the Enconius and EDC gap?
Well, both are used, but generally the safer one is the Kaplan approach. The EDC approach is safer because the collateral ligament is posterior to yours. You are not likely to damage the collateral ligament.
Collateral ligament. Thank you, sir. Any other question from audience or from the panelists also? They can also ask some of the question. No, then I invite Dr. Atal Soni for his presentation. He'll be talking on the K-wire fixation for the distal end of the radius. And he has got a long series for such fractures. So may I invite Dr. Atal? Can you share your screen and start presenting? Yeah.
Right. Can you see, sir?
Yeah. Okay, go ahead.
Yeah. Okay, thank you once again for making me part of this virtual conference. Thank you very much, sir. So I'll be talking only about the percutaneous K-wire fixation, and probably the other types of fixation will be taken care by Amit Vyas. So this was a fracture reported to the casualty and seen by the resident on the first day, and he reduced it beautifully. And he was very happy, bingo, water reduction, and sends the patient home happily. And when the patient returns back after 1.5 months, this is the horrific X-ray picture what he presents with. And the fracture is totally haywire and totally displaced. And with this grotesque hand deformity. Now, this resident and his 200-year-old master sit across the table and discuss what went wrong. And they don't know why this deformity occurred and will this deformed hand would function properly. But for this man, he did not agree, and he discovered, or he invented, or he introduced a K-wire, a wire to prevent these type of deformities. And the world over, now this started being used with various type of fixation and with various publications till date. So coming to the anatomy of the wrist is not that complex as shoulder or knee, but you need to take care of know 4 things. First, this pointer. First is, this is the scaphoid fossa, lunate fossa, triangular fibrocartilage complex, and this is the distal radioulnar joint, or called the sigmoid notch. 80% of the axial load is being borne by the distal radius and 20 by the distal ulna. So I would actually want you to look at these slides carefully, because these slides would tell us the indications of doing surgery. So the normal distal radius is in 22 degrees of radial inclination. The normal distal radius is in 11 degree of volar inclination, and the radial length is 11 mm more than the ulna. So the radius is 11 mm more than the ulna at rest. So I need to actually want you to look at this slide very carefully. The 22 degree angle, the 11 degree angle, the volar, and the 11 degree of the radial length, which is more at the wrist. So this So now we come to the indications. Looking at the previous X-rays, if you keep that in mind, then you know about the indications. We will go one by one. Now, normally, as I told you, the wrist, the radius at wrist is in a volar inclination of 11 degrees. But look at this X-ray, the fracture has gone dorsally. So if the dorsal tilt is more than 10 degree, it is an indication for surgery. If the articular step is more than 2 mm, it is indication for surgery, and that stands true for any fracture in the body. If the radial length, which I told you is 11 mm, if it falls short by 5 mm, then it is indication for surgery. If the radial inclination, which is normally 22 degree, and if it is less than 10 degree, it is indication for surgery. Plus, if there is metaphyseal combination dorsally or volar, it becomes unstable fracture and needs to be fixed. Plus, if there is a fracture of the ulna, not the ulnar styloid, mind you, a fracture of the ulna, it becomes an unstable fracture, needs to be fixed. And if the age is more than 60, the osteoporosis has set in, or the poor quality of bone, then you need to fix it, because otherwise there will be a collapse because of the poor quality of bone. Now, one more important area is this area. This is a die punch area, or the medial border of the radius, which articulates with the distal radial ulnar joint. If this area is fractured, this is a definitive indication of surgery. This needs to be fixed really well. Otherwise, you'll land up a problem in this joint and lose on pronation and supination. And one more indication for surgery is if the fracture displaces in the subsequent X-rays, you need to fix it because it has now become unstable. So look at this X-ray and this fracture. This fracture has lost all the radial length. It has lost all the radial inclination. There is a step here. The distal radial joint is totally displaced, and there is a combination at the metaphysis. Absolute indication for surgery. So you need to definitely operate it. Otherwise, you'll land up with this type of final result, which is really poor. So what kind of techniques can we fix the distal radius with? First is by the two styloid oblique wires, then the styloid and the transverse wires, then the styloid and the dorso-ulnar wire. This is the actually most common technique which is being performed nowadays, which is two wires from the radial styloid, and one wire from the medial side of the radius, dorsomedial side of the radius. So this one wire from the styloid volar, one wire from the styloid dorsum, and one wire from the dorsal of the radius medial border. First, the radial wire between the first and second extensor compartment, and the dorso-medial wire from the fourth and fifth, between the fourth and fifth compartment. Then there is a fixation called Kappanji wire fixation, which is intrafocal pinning through the fracture site, and which works on the principle of buttressing. The wires buttress the fracture against the displacement. This is how you do it. The wires have been passing through the fracture here and buttress the dorsal fragment here. One more percutaneous fixation in our armamentarium is external fixator. When you have fractures like this, totally displaced, comminuted, you are not probably comfortable doing only K-wire. So then you need to put an external fixator, which gives a good reduction, which gains the radial length, which gains on the radial inclination. Only one thing which it does not gain on is the palmar tilt, for which you need to reduce the fracture and fix it with K-wires. And you need to take care that you don't over distract, otherwise you'll end up in a RSD. Yep. For any K-wire complications, same is here, but you need to concentrate on two things. If you pierce the nerve or the tendon, you land up in a problem in these areas, and similarly, you land up in the RSD. Plus, if you do too much of rocking and rolling of the K-wires, you make the wires loose, and you tend to lose on the reduction also. So if you put wires, don't rock and roll repeatedly. So here I'll show you X-ray which was treated conservatively. Now see, this there is disruption of the distal radioulnar joint. The ulnar head is almost touching the lunate. And because the distal radioulnar joint is disturbed, the patient is losing on this pronation and supination. The patient can only rotate till mid-prone or mid-supine, not as in the normal limb. And similarly, normally, since the radial distal radius is in a volar tilt, but in this case, the fracture is totally tilted dorsally, so patient loses on the palm flexion. So now few cases. So this is the fracture which asks for a surgery. Like it has lost on the radial length. The radius should have been somewhere here, but it has collapsed till here. So you lost on the radial length. You lost on the radial tilt. There is combination here. So this needs to be fixed. And yes, well reduced and fixed well, and the results good. Again, dorsally displaced more than 10 degrees, needs to be fixed well, and good. So in fact, any type of fracture, if you can really reduce it well, so in this case, it is a volar fracture, not classically a Burton, I would say, but yes, it's a volar displaced fracture, not even Smith also, but it is a volar displaced fracture. And if you can reduce it well and fix it well, it does well. You have almost as good as normal range of movement. So this is a fracture which has all the ingredients of a classical fracture, which needs to be fixed in any case. So you see, you've lost a radial length here. The ulna is abutting the even beyond the lunate. Too much of loss in the radial length. The radial inclination is totally almost zero. The fracture is displaced dorsally more than 20 degree. There you see the dipunch fragment, the medial border fragment, which articulates with the distal radial joint, which is totally disrupted. So this is a fracture absolute indication for fixation. Again, almost similar, loss of the radial length, loss of radial inclination, total dorsal shift, and loss of the distal radial joint. And there you see the dipunch fragment also. So again, an absolute indication for surgery, reduced well and fixed well. Final result, good. So a bit of encroachment of in the percutaneous fixation. So this is a dipunch fracture, lunate load fracture as it is called. This is a fragment of the distal radial joint disruption. So what we do is we just do a minimal invasion, put a joystick, lift the fracture if you can, and if we can lift it properly, fix it with the K-wire like this, and yeah, good. So almost all fractures of the distal radius, if can be reduced well and fixed well, give good results. If reduced well and fixed well. Not like this, where neither it is reduced well, nor it is fixed well. Why? Because the K-wire has not even passed through the fracture fragment. So there you are bound to fail. Thank you.
Thank you for a lovely presentation, Dr. Atal Soni. And now I invite Dr. Amit Vyas for his presentation. His talk on treatment strategies for the distal end of the radius. So Amit Vyas, yes, please.
Am I audible, sir?
Yeah.
Yes.
Go ahead.
So thank you, organizer, for the opportunity. So I will discuss some treatment considerations in distal and radius fractures with intra-articular extension, as Dr. Atal Soni sir has demonstrated very well about the K-wire fixation. But once the fracture extends into the intra-articular surface, one instability component is added. So we will discuss some treatment considerations in these cases. Like this young boy, he had some fracture of lower end radius. He was initially treated by the plaster technique, but later on, he presented with decreased range of movement and painful wrist. Then on after 7 months, this was the X-ray picture showing the sclerosis of the radial articular surface. And when we went for CT, there was a large void in the lunate fossa of the radius. And because this was the basically Dupuytren's fracture, which needs treatment by open reduction and lifting of articular surface, and this disabled this young man to decrease range of movement and painful wrist. Now only option is arthrodesis of the wrist. So articular congruity is important to prevent arthritis. So while doing the decision for the uh, selecting the treatment for the interarticular fractures, we need to consider all the following facts, and most important is the fracture configuration. Fracture configuration can be classified by AO technique. So it is difficult to remember, but it will guide you to the treatment strategy. Like A, I have not included intensely because it includes extra-articular fractures. B, these are the intra-articular extension. B1, if involving a radial styloid. B2, if involving the dorsal rim. If B3, it is volar rim. So in all these fractures, there are different treatment guided treatment modalities. Like radial styloid can be fixed with the K-wires only. Dorsal rim, you need to go dorsally and reduce the things. Volar rim, you need to go volar and reduce the volar rim. And these B4 and B5 are the Dupuytren's fracture. B4 is the lunate die punch and B5 is the scaphoid die punch. Here you need to elevate the articular surface. So different treatment modalities are there. And C is the complex fracture. It may be with dorsal displacement, with volar displacement and metaphyseal combination. And it is involving more than one column. As we all know, the 3-column system, which involve radial column, lunate column and ulnar column. So how to know this fracture configuration? We will learn with this example. This 55-year-old doctor, he had some fracture lower end radius. By casually seeing, it seems some extra-articular fracture, but with careful examination, you can see some fragment on the ulnar side. When CT was done, you can see this volar ulnar corner. This is most important to know this configuration because this is important cause for displacement later on if this fragment is not addressed. So we went and chosen the implant like this, that it should, one screw should buttress and fix this volar ulnar corner. And because as he was doctor, after 10 days he started his OPD, and he has a different writing habit by doing wrist flexion. So after 3 weeks he started his writing also. So while choosing the treatment, we have to consider the patient's requirement also. Then fracture configuration also guide us to choose the approach. Like this fracture, it is a complex fracture having radial styloid fracture and also lunate fossa fracture. In the CT, you can see this lunate fossa, the volar lunate fragment is upside down. And he was 65-year-old male injured. So we need to go by volar approach because all the things were in volar side. So went by the volar approach. We turned up this fragment, and then it was, now when it is turned up, then it is reducible. Now you need to fix with the rim plate the things, and the styloid fragment can be fixed with the wires. And as DURG was unstable after radius fixation, so we need to fix with a pin. So although because of this difficult fracture, he was able to achieve a considerable range of movement. This another example, this 20-year-old male with road traffic accident, he had mainly comminution on the dorsal side, and you can see the whole wrist is subluxated dorsally. So this is the indication where we need to go by the dorsal approach. This is the CT showing the same thing. You can see that this dorsal fragment. So we went by the dorsal approach and fixed with the dorsal buttress plate, and radial column was fixed with wires. And later on, you can see this is the articular congruency, and he's having a good range of movement with maintained articular congruity. So one important thing is that sometimes the condition is like this. He has some initial this fracture. It was fixed with someone else with the plate, but later on it displaced again, and you can see the DORJ is dislocated. You can see this DORJ is dislocated, and patient presented with complaint of this prominence of ulnar head after 3 weeks. So at this time, there were two problems, because radius was also collapsed and DORJ was dislocated. So we went again, and we removed the plate, and then it was reduced. Now you can see how much void is there, and radial height is gained, and it is again because it was initially fixed here, so we chosen the rim plate, and now even after fixing of the radius, you can see there is prominence of the ulnar head, and after fixing, make this a habit of checking. So you can see on the pronosupination, your radial ulnar head is coming out, and it is quite unstable on examination. So in the previous X-ray, we know ulnar styloid fracture was there, so we think DRJ is dislocated because of this TFCC. So this ulnar column was fixed with the wires. Now it is unstable constraint. So DURJ injuries should not be missed. But sometimes the conditions are not favorable. There is too much comminution, comorbid conditions are there. Sometimes economic constraints are there. Patients are not able to wear the, because these roller plates may be costlier to someone. So we can use this minimally wire technique. Fracture is reduced and can be substantiated with the external fixator. I should acknowledge Dr. Vineet Arora because he has done this case. So after doing the fixation, we should always consider these type of these arms. Means we should aim for the articular congruity. We should maintain the radial length and alignment. We should encourage the digital motion, wrist and forearm, and stability of reduction should be there until healing of the fracture. And whenever these type of plasters should not be applied because it may hinder the range of movement of the fingers. So always encourage digital movements and also encourage the shoulder movement and elbow movement if possible. So in conclusion, articular congruency and radial height should be maintained in all cases. All variables should be considered while considering the decision making. Most important is the fracture configuration. This fracture configuration also helps for the selection of the approach as well as the implant. The associated DRJ injuries should not be missed. Proper plaster techniques are important, and encouragement of digital movement is the priority. Thank you very much for kind attention.
Thank you, Dr. Amit Vyas, for presenting well in time. Here I want to ask you one question. When do you want to fix the fracture of ulnar styloid fracture?
Sir,
ulnar styloid.
Sorry. Sir, as I told in the talk also, that we after fixing the radius, always check the instability of the DURJ. If your DURJ is unstable, then it comes to the fixation of the ulnar styloid if associated fracture is there. If ulnar styloid fracture is not there, then initially you can just do one radio ulnar pinning. If ulnar styloid fracture is there, especially if it is involving the base of the ulnar styloid, then you need to fix the ulnar styloid. I think it is clear, or you want to ask?
Thank you, sir. Any questions from you from among the panel? Sir, would you like to ask some question from Dr. Atal Soni and from the Amit Vyas, sir? Kotwal, sir, would you like to ask some?
I just like to make a comment. Both actually presentations were very good. I must say, Dr. Atal Soni also showed some good cases with very good results, just with K-wire fixations, and so also even Amit Vyas showed some difficult cases. Just want to make a comment about the ulnar styloid fracture that you said. Earlier, most of the advice was to fix the ulnar styloid with whatever possible, with a K-wire, with a screw or whatever. Nowadays, unless, like what rightly Amit said, unless if there is instability of the DRUJ, the ulnar styloid does not need to be fixed. And or else if there is a very large fragment, he rightly said, from going from the base, which is causing the instability, then you may fix that. Otherwise, you can leave it, and there is no fix the radial styloid the ulnar styloid if there is no instability.
Thank you, sir. Now I invite Dr. Amit Mittal for his case presentation. Amit, can you share your screen?
Yes, my screen is visible, sir.
Yeah, okay. And very well visible and audible. You just share your screen now.
Thank you, Jaswant sir, and my teachers and seniors. So after going through this elbow, wrist, and this nerve injury is my topic associated with the elbow fractures. So it's a decision making. I will start through some cases in this. So this is an X-ray of a 30-year-old male. He fell from bike. It's a closed fracture, and pre-op there is a wrist drop in this.
Amit, your screen is not visible.
Yeah, we cannot see.
You cannot see.
Amit, share the screen.
Okay. Wait.
Please share the screen.
Actually, I tried. I thought it is visible now. Now, wait 1 minute.
Not yet.
Not yet.
No.
Okay, wait.
Yeah, now.
Yeah. No.
Now it is visible, sir.
Yes, sir.
Okay.
Now go to the full screen.
Yes, sir. Now it is visible, sir.
Yes.
Sir.
Okay.
Go ahead.
Okay, sir. So it's a X-ray of a 30-year-old male, and it's a closed fracture, and there is a pre-op, there is a wrist drop in this. So if we see what is there in findings in the X-ray, what information we can get. So we know that it can be it's the wide displacement of the fracture fragment. There is a butterfly fragment. There is a gross overriding of the fracture fragments. So as a doctor or surgeon, we always think what kind of radial nerve injury it could be in this case. So we think that it can be tear or laceration, entrapment, or neuropraxia, but we are not sure which one of them it is. So answer it is this: we will fix it first, and then we will explore that what could be the injury after exploration. So after good fixation of this distal humerus, then we found that the radial nerve is intact, and we could able to see the radial nerve through the posterior approach itself, same approach. Now then the next question that comes is, what is the quality of the radial nerve, and is there proximal avulsion injury in this radial nerve injury or not, that we cannot able to see through this posterior approach. Then radial nerve quality, we found that it is good as it is seen in this video, and there is no give way feeling after tugging of the radial nerve. So we think that there is no proximal radial nerve injury. But with this, sometimes the question to all that we think that, is this way of checking the radial intactness is correct or not? Can we see the radial nerve through the posterior approach or not? Or is this empty area in the lateral side in the distal humerus approach is normal or not? If you see on the medial side, it is totally like a curtain, but on the lateral side, there is a big hole is there as it is seen by this yellow arrow. So with this, so what I found that this wrist drop is not because of this radial nerve, it is because of the wrist extensors which were avulsed from this supracondylar ridge of this area. But still in the, they could be associated injury also with of the radial nerve also this, but we thought that because it is only the wrist extensors, it is there in the posterior approach, so this is the only reason. But still, till the nerve doesn't recover in the time, so we cannot assure that through the posterior approach nerve is injured or not. So pre-operatively, what we have missed in this radial nerve examination is it active extension of the fingers and thumbs were present or not, that I have not seen. Other sensory examination of the first web space, that is also we have missed in this case. So these two things could indicate about the nature of injury. It is just avulsion injury or the radial nerve injury, by which we could be sure during surgery that it is because of nerve injury or the extensors. Now let's discuss another case. This is a distal humerus fracture. Young boy fell from a bike. It is also a closed intra-articular fracture with no wound seen. Ipsilateral closed intra-articular distal radius avulsion, rim avulsion fracture is also there. And in this pre-op, wrist drop, finger drop, thumb drop, loss of sensations were there. So this the information that we get through the X-ray is that it is a comminuted intra-articular fracture, but there is no wide displacement of the fracture fragments. So question comes is what kind of radial nerve injury? Again, it can be tear, laceration, entrapment, or neuropraxia. But because it is not wide displacement, we think that it could be just a entrapment or a neuropraxia. But the surety of this will become only through the when we'll fix it and then we'll explore it. So this is a rigid fixation of the distal humerus of the and the distal radius plating, as it is already mentioned what fixation to be choose. I think it's the right fixation. Then we further checked it, is any movement is there on the fracture fragments or not. So there is a good elbow range of movement and there is no fracture fragment individual mobility. So to the same posterior approach, we are not able to explore the radial nerve because both medial and side it is curtained by the muscles. Now through the fresh anterolateral approach, we found radial nerve was found divided. Now when it is divided, then the question comes that the nerve should be done at the same stage or should be done as a second stage. So second stage, sometimes who don't think that we can do it same time because of long tourniquet time or not availability of the resource or skilled surgeon. So we can do it after full elbow range of movement also. So answer depends upon the availability of the resources and the skilled surgeon availability. We can choose any of them. So nerve surgery, if we'll do for the same stage and we have freshened the nerve ends and then we explored the nerve, that it is possible to approximate with elbow flexion, then what should we do? Should we do an end-to-end nerve repair or we should go for a sural nerve grafting? This is again a difficult thing. So I don't know which option is better for this patient, but I am in a favor of sural nerve grafting primarily. My logic is elbow joint is prone for stiffness if not mobilized early. With grafting, I can follow the principle of rigid fixation early mobilization for satisfactory function in this reasonable time. So this is what I have done. This all ends were freshened and full elbow is extended and 3 sural cables nerve grafting is done under high magnification 24x Carl's microscope. And then at 4 months, there is a full range of movement of the elbow and wrist, but there is no active extension of the wrist at 4 months. Scar healed well. And then at 8 months, there is a good wrist extension and range of movement of the elbow, which is possible. So my take-home message for this is careful neurological examination is essential. Fixation should be rigid to allow early range of movement and explore radial nerve, and decision is to be based on expertise and availability of resources. Thank you so much. Any questions from the panelists, or if time permits, I can go for the other cases.
One more case, please.
Okay.
One more case you can present.
Okay, I'll see this. So I will see this case. It's a young boy from Gurgaon. He had a weakness of this wrist, fingers, and the thumb from the gradually developed weakness in the last 1 year. And he had an operation done 4 years back. And it's a distal humerus fracture fixation for which this is the X-ray, post-op X-ray at that time. So anyone want to comment on this X-ray? Any abnormality or fixation is good? Okay, anyone want to, through the panelist? Kotwal sir, do you want to point anything in this X-ray for the cause of radial nerve injury in this? Okay, so this is a distal. Yes, sir.
Looking precarious.
Okay, yes.
And then this screw, one of these screws actually is longer because the nerve would come anteriorly at this level, or in somewhere it is again.
Yes, sir.
जैसे ही वो स्टार्ट का कर देना
Yes, sir. So it could be either because of the screw or the big long K wire which is going to the radial side from the medial side. So
It's not
वो एक
injured the nerve there. Late.
so here this is a nerve which is this is a wire that you can see through this scissor, and through this we could not able to make out that the nerve is how much is injured. It is completely shattered. Only just by the epineurum it is intact. And then this is then the nerve is freshened and grafting is done in this case. And the wire is also taken out and then fixation done, and this is okay. So this is one case that I want to share. Okay, sir.
Okay, thank you.
Thank you so much, sir. Thank you so much.
Thank you very much. Any other question on this talk of Amit? Dr. Atal, do you want to ask some questions, or Dr. Amit Vyas?
I actually am I'm really not able to understand how could he explore the radial nerve in the first case. I mean,
In the first case, yes, correct. So because there was a rent in the supracondylar wrist to the lateral intermuscular septum. So through the rent itself, when I went and start searching, could I able to see the nerve there through the same approach? So I able to find it from there, but it is only because there was a avulsion injury of the wrist extensors from the lateral supracondylar wrist. That's why I could able to see this radial nerve. Otherwise, normally in a distal approach, posterior approach, we cannot see the radial nerve through this approach.
excellent.
Yes, sir.
Excellent done, Amit.
Thank you.
Excellent. So, any final words from Professor Kotwal, sir, on this conference? And
good cases and very nice job that he has done. One thing I would like to say, this is really creditable because most of the times when the nerve is injured and in the amidst the fibrosis, it is easier to go away from the area of fibrosis or injury, from distal to proximal, and then from the normal tissue, then you come to the area of fibrosis. So that way it makes life a little easy. But he has really been able to find it out right there at the site of the injury itself. That's really very creditable.
Thank you, sir.
so, since there is no question from any audience and no message from the organizers also, shall we conclude now, or any question from any panelist?
time is
So
over.
if we have some time, I can make a comment
Yeah, sure.
on the ulnar styloid fracture. So normally even if you have a comminuted fractures of the distal radius, the fracture at the distal radial joint, the TFCC almost always gets some bit of disruption. But still, when you reduce the fracture well and you reduce the DRUJ well, there is absolutely no need to fix the ulnar styloid, and almost in 95% cases, you actually don't need to fix the ulnar styloid. So only in the case, as Amit Vyas showed, that even after the proper reduction and fixation, still the DRUJ was unstable, then either you can fix and if in that case, if the ulnar styloid is not fractured, then probably there is entrapment of some tendon there. So you need to explore there and search out for if there is some tendon which is there.
Shall I comment?
Yes.
Yeah, sure.
It may be TFCC injury also, sir. So
Yeah.
if it is avulsion of the TFCC, then
Yeah. So do you ever have asked arthroscopic surgeon to go inside and see for it? and repair something?
No, sir. But
Actually,
people, literature has shown that simultaneously people do wrist arthroscopy and a lot of DURG injury, TFCC injury has discovered.
yes, sir.
Invariably, it does. Invariably, the TFCC does get damaged in a comminuted fracture. There is no doubt it. But if well reduced, it doesn't cause any problem actually.
Yes. So, as Kotwal sir also told that after fixing the radius, you just check the instability of the DURG. If DURG is
Absolutely.
stable, you need not to do anything.
Absolutely.
If it is unstable, then go and see the cause for the instability.
May I comment, Atal Soni sir?
Yes.
Actually, we do wrist arthroscopy quite often. And recently, I did wrist arthroscopy associated with Vineet Arora at Jivan Rekha. So there, my question to Kotwal sir that it is right that we should not fix ulnar styloid fracture unless there is an instability. But sometimes we have a patient after not fixing the ulnar styloid and all good range of movement, this patient having ulnar side wrist pain. And we come to know that it is because of the ulnocarpal impingement, because of that ulnar styloid, which is impinging this lunate base and the TFCC. So how to address that pre-operatively or during surgery so that this risk will be lessened? That is one which is very big concern for us as a wrist arthroscopy.
This is a very good point. The basic thing about it is that restoring the length of the radius. If the length of the radius is restored, then the ulna will not be longer, because the impingement and the abutment comes if the ulna is a little longer, and then it abuts against the trachytrum or the part of the lunate as shown in many cases by Dr. Atal Soni. So if that is addressed, then the abutment issue does not really come.
Okay, radial length should be absolutely correct. Okay.
Normally, the radial styloid is, like shown earlier also, is longer than the ulnar styloid by about 10 to 11 millimeters.
Yes. Thank you so much, sir. If time is there, then I can show one more case if it is there.
Sir, shall I leave? Because I have to join the another.
Yes, Amit, yes, any final comment on this conference, or you want to add on to your talk? Amit Vyas, you want to add on something more on this your talk, or?
So good afternoon, everyone, all the delegates. This session is for 45 minutes and we are presenting a pediatric orthopedic trauma, all case-based. There is no much of theory. So next 7 cases will be all pediatric trauma, and we have a national faculty, Dr. Alaric Arugis. He is a vice president of pediatric orthopedic system, and he is attached with many international projects as well as an experience of more than 15 years. Dr. Sapnil Kene is also from Mumbai, and he is currently associated with Apollo Hospital and Reliance Hospital, as well as he is an honorary associate professor at Grants Medical College, Mumbai. And third is Dr. Chasnel Rathore. She is a senior pediatric orthopedic surgeon with 15 years of experience, and she has been attached to various hospitals in Mumbai. And from our state faculty, we have Dr. Kapil Gangwal, is the senior most pediatric orthopedic surgeon at Santokba Durlabji Hospital. And as well as we have budding Dr. Deepak Khurana, as well as Gaurav Garg and me. So next 7 cases will be pediatric trauma, and without wasting time, I will invite Dr. Alric sir to present his first case on irreducible supracondylar fractures. Over to Alric sir.
Thank you, Rajat. I must thank the organizers of ROSACON for inviting me to be a faculty for this very interesting session. I think I need to share my screen. You'll need to allow me to share screen. It says host disabled screen sharing.
Sir, yeah. So our first speaker is Dr. Alric, and he wants to share his screen for presentation. So you allow all the speakers to share their screens. Sir, over to Alric, sir.
Yeah, allow, sir, allow.
Dr. Alric needs to share his screen. Kindly help me. Just a minute. Yeah.
हेलो हाँ जी
Yes.
हाँ सर
9160
सर्टिफिकेट मीटिंग के बाद में आपको पॉपअप आ जाएगा, वहाँ से डाउनलोड हो जाएगा सर लॉगिन है।
Please unmute everyone.
हाँ पूरी कॉन्फ्रेंस खत्म होने के बाद।
Yeah, please mute. Yeah.
All right, can I go ahead?
Alright, go ahead.
All right, great. Thank you everyone again for attending this online session. And I'll very briefly speak on a very common fracture that all of us see, whether we're general orthopedic surgeons or pediatric orthopedists, and that's the supracondylar humerus fracture. And for this case, I'm just going to present just one aspect of the supracondylar humerus fracture, which is the irreducible type, which will occasionally come to us in our practice. And I've labeled this, I've titled this presentation as irreducible. There's a lot of background noise, Rajat, so can you ask them to mute themselves?
Yeah,
Please?
so I think this host is
लोगों का अभी भी चल रहा है।
just.
Great, thank you. So as you can see, I'm not going to talk about the management of a routine supracondylar fracture, but I'm going to focus just on this very unstable variety, which we call the Gartland 3, or more recently called the Gartland 4, which actually is a very unstable multi-directional fracture where the soft tissue has been stripped so completely from the distal and proximal fragments that there is no stability provided by the periosteum or the soft tissue. Of course, the treatment here is a close reduction and mandatorily a pinning. We must understand that this fracture is associated with a marked elbow swelling and sometimes an irreducibility. And this is the one that we must be really careful about because it's often complicated with nerve and vessel injury. So before looking at the X-ray, we must take a look at the clinical assessment of these patients really carefully. And it's challenging at times with very young children who are apprehensive because of the pain and because of the swelling to cooperate with a full neurovascular examination. But it's still important and behooves all of us that we must be aware that these are the children where we must have a very high index of suspicion for irreducibility, the fact that they can have neurovascular compromise, and therefore checking the nerves, especially the median nerve and the anterior introitious branch especially, is very crucial for these fractures. So when you see a clinical presentation like this, where you have a large hematoma ecchymosis of the front of the elbow, or sometimes even a pucker sign, watch out for nerve involvement. As you can see, this child has an anterior introitious or a pointing index sign, and the X-ray will look like this, where you see a very marked displacement of the fragments. So these really comprise about 8 to 10% of all supracondylar fractures. And of course, if you have a referral practice where you deal with a lot of tertiary injuries, you might find a higher incidence of these fractures. The reason for the irreducibility is because of the brachialis muscle, which is entrapped between the proximal and the distal fragments. But at times, even the brachial artery or the median nerve can be entrapped between the two fragments. So we must be aware of this. As I've said, clinically it's associated with marked elbow swelling and typically what's called the pucker sign. And originally we had reports which talked of a milking maneuver as described by Archie Beck in 97, where you actually try to milk the soft tissue over the proximal fragment because that's where it's actually impinging. The soft tissue over the front of the elbow has been impaled by the proximal fragment, and you try to milk it over the proximal fragment to try and disengage the two fragments. I have not really been very successful with this technique. I always use this as the first choice when I have irreducible fracture, but it doesn't always work in my hands. So here are a couple of techniques that have been described. Some have been reported in literature. This is one which has been reported by a colleague, Viraj Shingade, when he did his fellowship in South Korea. Here's an example, as you can see, of a type 4 Gartland fracture with a marked displacement of the fragments. You can see how the proximal fragment has buttonholed through the brachialis muscle, causing that anterior ecchymosis and even puckering of the skin. And what the device is what's called the suction tip maneuver, where you make a small incision on the anterolateral aspect of the elbow. So that's the front of the elbow to and focus yourself on where we are. That's the neurovascular bundle lying on the medial side of the biceps tendon. So you make a small nick on the anterolateral aspect, insert the suction tip. The suction tip does two things. You connect it to a low volume suction or low pressure suction rather, And that helps to suck out some of the hematoma, which immediately reduces the pressure within the front of the elbow. And then using that same suction tip, you can push on the proximal fragment and then with traction and the usual maneuver, reduce the distal fragment over the front and then pin it in the standard fashion. So this is the suction tip technique which has been published by from South Korea, and I find that's quite a useful technique. Now, sometimes this technique does not work, and here are some of the pictures from that publication which show that it was then reduced and fixed in the standard fashion using a cross pinning technique. You may even choose to use lateral pins if you want to avoid the cross pinning. Here's an example of another patient who came to me a few years ago, and as you can see, all the signs of irreducibility. You must have a high index of suspicion, do a very detailed neurovascular examination. And the technique that I employed here after trying the milking maneuver is a leverage technique. And I haven't seen this reported before when I devised this technique, but then I think later on there has been a publication on this eventually. So what I do is I make a similar small little nick anterolaterally, just like the suction tip technique, insert the curved hemostat. And what that hemostat does is to first clear off the soft tissue from the front of the proximal fragment. So obviously that step cannot be seen on the C-arm, but that's the first thing, to sweep the soft tissue away from the proximal fragment. Then insert it up to the distal fragment while applying some amount of traction. And then using the hemostat, turn it around to engage the distal fragment and actually lever the distal fragment into place over the proximal fragment. This can be done under C-arm control, as you can see here. And once that is done, you can remove your hemostat. That's a good reduction. And then you can pin it in a conventional manner, either with a cross pinning or with a lateral pinning technique. And that's how the patient was reduced. You must be aware that one type of supracondylar is known to have irreducibility, and that's the flexion type of supracondylar. It's not very common. It comprises about 2% of all supracondylars, and here you have directly a fall on the elbow. What's important here is, as K. Wilkins rightly pointed out, that when you see an anterolateral displacement, that's a dead giveaway for a flexion supracondylar. And important to note is that the distal fragment may not be necessarily completely flexed, but the fact that it's not extended itself gives you a definition of a supracondylar of a flexion type. And K. Wilkins has shown how when you open these fractures, they have actually herniated out through the medial intermuscular septum, impinging on the ulnar nerve, and therefore this is one fracture which is known to have ulnar nerve paresthesia. So here again was this child who underwent an open reduction through the anterior-medial approach and ultimately had a good outcome with an open reduction. So just to finalize, the conclusions therefore of an irreducible supracondylar is that a close reduction and pinning is a standard of care for these very unstable and displaced supracondylar fractures. Attempt various of these novel mini-open techniques using different methods of direct manipulation and leverage. Free up that interposed soft tissue carefully, understanding that at times the median nerve or the brachial artery may actually be entrapped. So keep a close watch while doing this maneuver. And open reduction may be required only occasionally, especially if you have a flexion type of supracondylar. But I think we have been fairly successful, even in these irreducible forms, to get a good mini open reduction rather than doing a very formal open reduction in these displaced fractures. And of course, it goes without saying that one must keep a close watch on the neurovascular status, admit these patients overnight, and discharge them only the next day after you're sure that there's no compartment syndrome and that you have a normal nerve and vessel condition of the upper leg. Thank you very much.
So thank you, Alric sir. We can take the questions at the end of the presentation if the time permits. Now I invite Dr. Swapnil Kenny to present his talk on trash lesions.
For us to stop his screen share.
Yeah, so I've stopped share now.
I can still see the screen.
Yeah. Yes, Dr. Swapnil.
Very good afternoon to all the viewers. At the outset, may I thank Dr. Jayan Sen, Dr. Rahul Katta, Dr. Kapil Gangwal, and Dr. Rajat for having me here at ROSACON. I'll be speaking on elbow trash lesion and why is it a predator which is lurking in the shadows, not seen but very dangerous. So this is a 12-year-old female child presented with a history of fall a week ago. She had a significant elbow swelling, significantly restricted range of motion, no distal neurovascular deficit. If you look at this X-ray, this looks like a medial epicondyle minimally displaced fracture, less than 5 mm displacement, less than 15-degree angulation, so definitely conservable. But there is something happening on the lateral side, specifically in the radial head. You can see a loosened shadow. And if you look a little closer, there is some sort of an osteochondral fragment which is seen, which requires further evaluation. So intra-articular radial head fracture was seen when a CT scan was done. This was not visible on the X-ray, but we could see 3 different fragments here. There was a restricted elbow range of motion under general anesthesia. When we opened it from the lateral approach, we could see that there was a completely displaced 3-part intra-articular radial head fracture, which was not obvious on the X-ray. This was fixed with Herbert screw fixation anatomically. And eventually patient went on to do well. So the question was, what kind of a fracture has the radiological appearance seems harmless? And these are what we call as the trash lesions. First described in 2010 by Peter Waters and his colleagues. And a trash is basically a small subset of lesions which are easily missed on X-rays. They may be osteochondral injuries which are insufficiently treated at times and usually seen in children less than 10 years of age. There is a different myriad of these kind of injuries, right from unossified medial condylar fractures which are not visible, to complex osteochondral injuries, to radial head fractures like in our case, to lateral condylar avulsions which are not seen, to Monteggia fracture dislocations which are again not really visible on X-rays at times. Now, evaluation of the trash lesion, you really need to have a very strong history of a high energy trauma. The examination will always reveal more swelling that is seen, which is misinterpreted by the radiographs, and flexion and extension of the elbow as well as rotations are significantly restricted. If you examine these patients closely, the radiograph will show some sort of a bony fragment, but special imaging is always necessary, either in the form of an ultrasound by an experienced ultrasonologist if the child is small, MRI scans in most cases, sometimes an intraoperative arthrogram, but usually more than an X-ray is what is required. Maybe even a combination of different investigations are required. You need to fix them. You need to fix them anatomically, either with screws or small plates or anchors. The fixation has to be rigid, and many a times you also require soft tissue ligamentous reconstructions. You have to immobilize them either in braces or in casts, but for a reasonable amount of time, so that they end up becoming gummy, and then you can mobilize them. They have multiple complications like heterotropic ossification, periarticular contractures, and avascular necrosis, and hence it is not meant for people who have not seen these kind of injuries. But the biggest complication with trash injuries is the failure to pick them up, the failure to treat them accurately. Rather, they are treated in casts and splints because we feel that it is an innocuous fracture when it is not. They are referred late because they are picked up late. And whenever they are referred late, anatomical reconstruction will not be possible, and that may cause the problems of permanent malalignment, limited motion, and can affect the functional range of motion. So to conclude, you have to have a high index of suspicion, early additional imaging, and very aggressive surgical care once you have a prompt diagnosis to treat these trash lesions. And these are not as simple as they appear. So in short, it is a predator which is lurking in the shadows, and unless you're very, very certain, this can come and hit you many a times and is not as benign as it seems. I thank you all for the attention. Thank you so much.
Thank you, Dr. Sapnil. I know it's very difficult to present trash lesion in 5 minutes, but still you have done a very commendable job. And if there are any questions, I'll message you later on if the time permits. Next, I will invite Dr. Chasnell to present his talk on both bone forearm with ulnar nerve injury. Dr. Chasnell.
Yeah, so good afternoon, everybody, and thank you, ROSACON, for having me here for this online meeting. And I would be presenting a case of distal both bone forearms with an ulnar nerve injury to understand what actually went wrong in this. Okay, so this was a 12-year-old child, and he presented with a 2-day-old fracture with a distal at the distal 1/3. The child was primarily treated by, referred by the primary surgeon, where he had attempted close reduction and cast, and post cast application, the child developed tingling over the ring finger and little finger, and there was decreased sensation. And there was a lot of swelling. So he had to actually cut the cast, put him back in slab, and he referred him to us. So we had a quick USG evaluation to assess if there was a nerve entrapment, did it require an open reduction, or to plan what needs to be done intraoperatively, whether an exploration of the nerve would be required. And it showed that there was just a nerve contusion and there was not a tear or impingement. So currently these were my concerns, and I had the following options: that yes, this fracture was probably unstable and it needed a fixation. Should we wait, or should we directly go for an open reduction in view of the injury? And as the child was around 12, should it be fixed with plate or a KY? And secondarily, for the nerve injury, again, should we wait for the recovery or explore it? And if after exploration, would it need a repair? So actually, I called a nerve reconstruction surgeon and we did open up the fracture. And this was the incision. We saw the nerve. There was a lot of contusion and swelling there. And post this, we fixed it minimally with KYs. We did avoid another incision because a plating or anything else would need a separate incision, and we didn't want to fidget with the nerve injury already here. And since this is a low ulnar nerve injury, we see that there is sensory aspect involved more, and abductor digiti minimi and introtia involved. So this is how the child looked post-operatively with, and at 1 month post-op, I did a EMG for the child and it was still showing no response, and the ADM did show a delayed and very low amplitude, and the fracture was doing good. And after 1 month follow-up, I did remove one of the K wires. And at the subsequent EMG, again, there was, at 3 months, we started seeing some recovery. But post that, around when the child came for the second follow-up for the removal of the short arm brace, we noticed that there was an angulation. And yes, this was a bit of concern because the child was already 12 and some months. But luckily he still managed to remodel. That was a good thing. And this is currently at 11 months post-op. He has done well. And even his nerve injuries went ahead and did very well. He currently doesn't have any deficit. So how common are these problems? So when we come across such problems, of course, we start searching the literature for answers. And so far, some 14 cases have been reported from various parts of the world. And usually it occurs probably because of primary insult or maybe nerve entrapment during reduction, or they could be delayed in getting entrapped in the callus. So important is it can be avoided by how we maneuver these fractures during the reduction. At times we know that we exaggerate the deformities in distal end, particularly if both the bones are involved. We try to disimpact and we try to disengage. We do a opposite deformity, and all these are known for causing interposition. So we need to be careful about these particular things, and it can be avoided. And plus repeated close reduction attempt should also be avoided in such cases if we are having any suspicion of nerve injuries. So primarily, like even Alrixa pointed out, it's important that we make a note of the neurovascular status of the child. And many a times we often notice in our regular practice that we just pay attention to this post-op and then we have no record of it pre-operatively. So for the nerve, since in this case, usually we would always want to wait and watch, but here since it was secondary to a reduction maneuver already, which was performed elsewhere and I was not sure about it. So it was wise to explore and get it sorted in the first place. When I look back at this, I had my own introspection or maybe a retrospection that in an attempt to constantly chase the nerve injury recovery, probably I have was in a hurry to remove the K-wire. And secondly, I even felt that instead of probably this kind of reduction, if I would have gone for such a intrafocal pinning with one Kapanji wire intramedullary, it would have been a much more stronger construct here. So this is not from this patient. This is just, I have picked from another patient, which I just retrospectively thought that this could have been a better pin construct rather than just this. And in that whole attempt of focusing on nerve, probably fixation was slightly compromised. And it does happen when we are focusing on too many things. Probably this could be thing. But to end, I think currently everything is well. The child has done very good. The fracture has remodeled, the nerve injury is doing good. And that's what we all always aim for, to give the best result as possible. So that's it. Thank you.
Yeah, thank you, Dr. Chasnal, for presenting such an interesting and rare case. I think the main message is to, document all kind of, nerve injuries before and after the surgery. So now I will invite Dr. Kapil Gangwal sir to present his talk on lateral condyle fractures.
Okay. Okay, thanks, Rajat. So just taking you across to another injury other than supracondylar, which is probably the most common. So this is a 3-year-old child who fell off a swing, and just give me one sec. Yeah, he fell off a swing and presented to the emergency room like this. And the resident looked at this, and he really didn't make too much about this injury. But if you see, there's a huge amount of swelling on the lateral side, and then one looks carefully, one can see a little crack in the lateral condyle. So these are innocuous injuries, often can be missed. And what you really need is X-ray in the internal oblique. So internal oblique AP view will show the fracture in profile, and this is something that we need to remember to diagnose these seemingly or minimally displaced injuries. So if we look at classifications, this is the type that we are dealing with here, and this is the controversial area in these fractures, because the more displaced fractures, everyone knows that you need to fix them and you need to reduce them, but the minimally displaced fractures are the ones which are the really controversial ones. So they're controversial because you don't know whether they're going to displace later on or not. And actually, if the articular hinge is intact, which is cartilaginous, you can't often see it. It's a stable fracture, but if the cartilaginous hinge is broken, it's unstable. So can we know by some means, looking at the X-ray, that whether this is going to be unstable or it's going to be a stable? Well, you can do an arthrogram or an MRI. Both are difficult in children because they need anesthesia. And if we look at the X-ray, this is a paper which talks about this, that if the articular fracture line does not extend to the articular surface, then it's probably the stable variety. But if it extends to the articular surface, and especially if the lateral fracture gap equals the medial fracture gap, then it's a unstable variety, which is highly likely to displace later on. So here's this child. The treating surgeon at that time decided that it was stable and probably was not going to displace, put him in a long arm plaster. And what's important is when we cast these children, to put the wrist in extension and forearm in supination to kind of neutralize the extensor and supination force on the fracture, which actually leads to the displacement. So this is a repeat X-ray after 1 week, which is another important point we need to remember, that these fractures displace, and most of these are going to displace in the first 5 days. So X-ray out of the cast in 1 week probably will show whether the fracture is displacing or not. Well, this surgeon at that time decided that this probably had not displaced so much, probably not a very wise decision in retrospect, but he decided to continue the cast. And this child returned at 4 weeks from injury. And at that time, the surgeon looked at this and saw that there was some evidence of callus formation, some kind of bone formation across the fracture, some callus posteriorly, thought that the fracture had united, left the child free out of the plaster and allowed him to range his elbow. Child comes back 1 month later, and you can see that there's a frank non-union at the fracture. So now this is real trouble. One doesn't know what to do here. Should one do an open reduction? Should one do a closed reduction? Should one wait further to gain full range of motion? Well, it was decided to go ahead and kind of stabilize this fracture. That's the kind of range of motion this child had at the time of the procedure. We attempted percutaneous screw fixation of this fracture. We didn't attempt to open it at all. And this is based on this study, which has looked at all these kind of non-unions of short duration. And their indication for the procedure was that the range of motion should be good and they should be less than 15 weeks from onset of injury. So this child met these criteria. This is at 6 weeks from injury from the screw fixation, and that's 3 months from screw fixation, and the fracture went on to heal uneventfully. And he had a fairly good range of motion too. So I think to conclude some learning points, about 11% of these seemingly undisplaced lateral condyle fractures will displace in the cast, and we need to be really careful. Majority of the displacements will be within 1 week from the injury. And percutaneous screw fixation works well for these delayed non-unions, especially if they are not too far out from injury, and adequate range of motion is a prerequisite for fixation. Thank you very much.
Thank you, Kapil sir, for such a nice case. I'll present the next case, and meanwhile, if there are any questions, we'll be taking at the last of the session. So I'll be, my presentation is visible?
Not
Hello, yeah. So I'll be speaking on post-traumatic physial bar. So he was a 5-year-old child. He fell from the bicycle.
Can't
And
see your screen, Rajat.
You can't see my screen.
You need to share screen.
Yeah. Is it okay?
Yeah.
Okay, so he was a 5-year-old male child, fall from the bicycle, complained of pain and swelling on the left wrist, and he was consulted nearby orthopedic surgeon. And if you see the X-ray, it's a classical type 1 Salter-Harris injury of the distal radius, and it was close reduction and KY fixation done by an orthosurgeon. The K wires were removed at 6 weeks. There was no pain, and it was advised physio to gain range of motion. After a few months, that is around 6 months, parents complained of slight deformity, and this was the X-ray taken at that time. And the orthopedic surgeon then, told the parents to wait and watch. But by the time, after 2 years of injury, there was a frank deformity in terms of progressive radial, along with ulnar overgrowth and DRUJ subluxation. This was the injury after. This was the X-ray 2 years after the injury. They came to me with this X-ray. So when we went for a CT scan of distal radius, we found that there was a completely bony bar across the physis in the central portion. And this is called a central bony bar. And because of this bony bar, there was a deformity in terms of radial deviation and ulnar overgrowth. So what were the treatments available at this particular point of time? We can wait. However, the deformity is going to progress. We can do a osteotomy in terms of ulnar shortening osteotomy or radial lengthening or any kind of dome in further radius. But all this osteotomy will last for only for a short duration of time because the child is still just 5 years old. So there's a third treatment option, which is called as bar resection. And what are the indications of bar resection? At least 2 years of active growth remaining, and as well as the area of the bar should be less than 50%. So based on this criteria, we actually decided to go for a bar resection treatment. And how do we do it? We just localize a bar under Siam with a K wire and then make a metaphyseal window, curated out this complete bony bar across the physis. And once the lesion is curated out, we actually prevent recurrence by putting either a cranioplast or a fat. I used the fat in this case to prevent recurrence. This was the immediate post-op X-rays. And this was the X-ray at the 6 months, which shows the X-ray is not very clear at that particular time, but at least the deformity was not progressing. And this was the X-ray at the 2 years of time. We noticed that the bar completely resolved and there was a restoration of growth of radius as well as achievement of the good ulnar variance. And these are the latest clinical photos of his child. He is doing all the activities as well as there is a resumption of complete growth from the radius. So what are the key points to learn here is that in a distal radius, we should always acceptability criteria of angulation, because there are high chances that this injury remodel even if we don't do an anatomical accurate reduction. Even if you plan to do a close reduction, they, it should not be added by unnecessary implants, that is K wires, etc. Because the close reduction is pretty much stable in these children if we apply a very good plaster. If at all these injuries are 1 week older, we should not attempt any kind of physial corrections, because there are high chances of growth arrest in these injuries. So we should wait for remodel, and in case if it is required, we can go for a late osteotomies. And even if you reduced it very nicely, their 5-year bar is always a possibility, and an adequate follow-up is always necessary to look the further progression of these injuries in children. Thank you so much. So now next will be Dr. Gaurav Garg, and he's going to present a talk on femur fractures.
Yes. So you need to stop sharing your screen.
Just a minute, yeah. Yes, Gaurav.
Yes. So I would be speaking on subtrochanteric fractures in children, and I would be mainly concentrating on the implant selection. So my first case is a 9-year-old girl with a history of fall from stairs at home, and there is a fracture in the proximal femoral region. It's a short oblique kind of fracture. The important thing is that the parents are very demanding, and we need to suggest a treatment which should be perfect with limited or no complications. Now, the other case is a 7-year-old male with a history of road traffic accident, and he has sustained a comminuted fracture of the femur at the junction of upper 1/3 and middle 1/3, and with a small puncture wound. Okay, so now just to have an overview, these fractures defined as the fractures within the 10% of the total femoral length, and they usually make up a small portion of proximal femoral fractures, and there are strong deforming forces which should be accounted for both in obtaining and maintaining the reduction. And they're often high energy fractures and which produce a variable fracture patterns. And also there is no standard guideline treatments available to treat these fractures. So now if we think of the types of fixation, these are all the different modalities we can think of. We know that the non-operative treatment is effective in a very young children, whereas the rigid nails are effective in the adolescent age group. So the treatment options in our case swings around the plate versus elastic nailing in our cases. So coming to the plating, the relative indication of plating in my practice is children less than 9 years of age. This may be an option for open fractures where the site can be exposed for debridement, and the pathological fracture is fairly common in this age group, and this affords the ability to obtain biopsy from the site. And for the heavier patients, the plating is better compared to the elastic nails. So this is a nice study by Vanderhavel et al., and they compare the titanium elastic nails to the plate fixation, again focus on subtrochanteric fractures. And they showed similar results in open or the submuscular plating versus the titanium elastic nails. However, they documented fewer complications, mainly related to the hardware issues and the union. So just about the advantages of plating includes that it's a familial approach, direct approach down to the bone. It allows a direct visualization of the fracture if needed, and the cast is rarely required with such a stable construct. The disadvantage is it does require a formal approach. There can be hardware-related issues, and the Boston group suggested a distal femoral valgus with a further growth, even with the more proximal fractures. And also the stress riser is particularly a problem compared to the elastic nails. Now, the elastic nails, the advantages includes it is good for children less than 11 years of age. It is better suited for the stable fracture patterns like more transverse or a short oblique pattern. And patients less than 49 kgs are ideal, and as you get into a heavier group, and they have a significant lesser stability, and they may be indicated for some soft tissue wounds around the fracture also. So there are several studies comparing the elastic nails in subtrochanteric region, and it's suggested it to be quite safe and effective. But if we tease out the complications, we see that the complication rate is quite high, close to 22%, with the majority of those being the hardware related and few malunions also. So now we look at this multicentric study where is focused on shaft fractures. We see that the use of titanium elastic nails, there is a 5 times higher chance of poorer outcome with weight more than 49 and 4 times greater chance of poorer outcome with age more than 11 years of age. However, this particular study does not include the fracture pattern, which also plays a role in overall construct stability. Just to have an advantages of nailing, that is, it is a lower operative time, this is less invasive, and there is less destruction to the surrounding biology, creating a better healing environment. The disadvantages of these constructs are they are flexible, so they require an additional augmentation either with the cast. Soft tissue irritation is particularly an issue in the distal aspect of the nail, and they are not as effective for the heavier patients. So our first case, which was a 9-year-old girl, we did submuscular plating, and the fracture healed well over a period of time. This is a 3 months post of fracture. The other case, which is a 7-year-old boy with a fracture of proximal femur. So we opted for a titanium elastic nails and supplemented with the external fixator. It was an exular fixator, and later on this fixator was removed and the child healed well. So just to summarize, the plates are an option for unstable subtrochanteric fractures, and the elastic nails are ideal for young patients with a stable subtrochanteric pattern, and elastic nails can be augmented with other fixation methods like cast or like external fixator. Thank you.
Thanks, Gaurav. Now I invite Dr. Deepak to present his case on pediatric neck fractures.
I'll share my screen.
Yeah. Yes, Deepak.
Yeah. So first of all, thanks Rosa, thank Dr. Katta, thank Dr. Rajat. So this is an 8-year-old girl presented with painful limb on the left side. There was a history of left-sided hip pain and fever for 2 months ago before this presentation, and followed by which trivial fall, after which she was not advised any bed rest. And on the basis of this X-ray, 2 of the senior orthopedic surgeons treated this patient as a transient synovitis, and patient was walking with the limp and no improvement was there. So when patient presented to me 2 months down the lane, on clinical examination, there was a flexion deformity of 20 degrees. Both the anterosupellic spine was on the same level. There was some painful rotation, even on jog of the movements. Straight leg raising test was weak as compared to the contralateral side, and there was a finding which was not corroborating with the presenting X-ray, which was true supratrochanteric shortening of 3 centimeters. So I ordered a fresh X-ray, and to the surprise of the patient, it come out to be a neglected fracture neck femur with the signs of avian, with coxavara, with proximal migration of the distal fragment, with some neck resorption in the center, with vertical fracture line, and recto version almost look okay. So questions which are needed to be answered before starting the treatment in such cases is like whether we need a preoperative MRI, what is the role of closed reduction, or we always need an open reduction in these cases for removing the intervening fibrous tissue, whether an in situ fixation is an option, what is an implant, whether there is a need for vascularized or non-vascularized fibula, role of valgus osteotomy, and preoperative planning. So there are many many papers in the literature, and the latest paper, which is published by Dr. Sandeep Patwardhan on the non-union, which is a review article which review all the other papers. So according to that, there is no role of any preoperative MRI, because our management plan never changes on the basis whether there is some features of avian or not. And gentle closed reduction to best possible position is one of the best method to use the closed reduction by using in situ fixation, valgus osteotomy to improve the biomechanics, and the use of fibula is restricted only in those cases in which there is neck resorption and fibula is used to reconstruct. So especially in delayed presentation, we evaluate for neck resorption, we check for the reduction in the interposed soft tissue, and we rule out any pathological cause. And the main plan of action in those cases is in situ fixation with neck reconstruction with fibula if there is a defect, and a valgus osteotomy. So what all these papers not defined is the use of what is an ideal implant to fix these type of fractures or this type of condition. So a single angle implant, whether it is a DHS or a locking plate or a blade plate, is an ideal for these cases. Why? Because these type of implants have several advantages over a simple molded recon plate or a double angle implant. So what advantages are those? The correction in these cases is precise as it is implant driven. These type of implants, they give better lateral translation for the distal fragment so as to maintain the neck length. There is no need to take out any wedges, only a simple transverse osteotomy will work. And as we are not taking out any wedges, so it equalizes almost to a maximum extent the limb length discrepancy which occurs because of the fracture. So we can preoperatively plan these cases either because on the difference of neck shaft angle on both the side or based on the Powell's angle. As we attempt to take the Powell's angle less than 30 degrees, so by both the calculation it was coming up to 35 degrees of correction is needed. So what will be the projection of the guide wire to be used? So it is also dependent what implant angle we are using. Like for example, we use a 130-degree DHS. So by subtracting the angle of correction needed to, we'll get the projection of the guide wire angle, which is in this case is 95 degrees. So the plan was in situ fixation and using a 130-degree fixed angle pediatric DHS, non-vascular fibula or a 4 mm scissors, depending on the space, whether we get the space to fix the fibula or not, and add on a valgus osteotomy to improve the biomechanics. So on intra-op close reduction, we were, with the help of abduction and internal rotation maneuver, we were able to improve the varus part. So the neck shaft angle, which was initially 105, comes up to 120 on intra-op evaluation. So
dear delegates and friends, because it is the last session of the Term ROSACON, but nevertheless, it is the very, very important topic that every orthopedic surgeon faces in day out and day in. The implant infection varies according to place and per person, about 1 to 5% total number of cases operated. It is a nightmare for the orthopedic surgeon. What I consider is, it is not 1 to 5% incidence of the infection, but when the patient suffers with the infection, it is 100% for him. So we have Alexa speakers with us. They will enlighten the various aspects of the implant infection. I forward to Dr. Solanki for further proceedings.
Thank you very much, Dr. Gupta. Just to give a quick start to the session, let me introduce our chairpersons. Dr. Mahesh Gupta is a senior retired professor from Medical College, Ajmer. Dr. Sharma is a senior orthopedic surgeon in Sikar. And the overseas faculty, we have very esteemed faculty coming from King's College Hospital, London. Mr. Om Lahoti, who has been working there from 2003 as a consultant. He has trained in Osmania University, Hyderabad, and following that, he had his training in Dublin, south of London, and also in Kurgan to learn the Elizabeth technique. He's interested in lower limb trauma, limb lengthening, and children's orthopedics. And with him is his own team member, Mr. Naveen Abhishetty, who also hails from Osmania University, Hyderabad. So welcome both of you from London, and thank you for participating in this ROSA midterm conference. Just to tell you something more about Mr. Naveen, he also trained in Sheffield and has an interest in complex lower limb trauma, malunion, non-union infection. And together, Mr. Lahoti and Mr. Abhishetty have several publications in this difficult topic. So we cannot have any better faculty to discuss peri-implant infection. So let us start with the first lecture. And I will also introduce Dr. Rajesh Goel, who is the professor and head and also our current president, along with his colleague, Ashutosh, who will be joining from Kota to participate. Dr. Arya was supposed to be on the panel, but he couldn't join due to some pressing engagement. So we start with the protocol for prevention of peri-implant infections and how to diagnose. Over to you, Mr. Abhishetty. You can start with the screen sharing. Everyone else has to mute. There is a channel, so everyone else has to mute their
lot of background noise.
Yeah, okay, just a minute, Mr. Naveen. Navneet, you have to make sure some of your team members' mics are on. Now the chatter has gone. Okay, you can start, Mr. Abhishek.
Ready. Okay, good afternoon, ladies and gentlemen. Let me first thank Mr. Anand Arya and the organizers for asking me to be part of the ROSACON conference. Peri-implant infection or fracture-related infection is a serious complication, and we need protocols to prevent it. It can be a diagnostic challenge. There are a range of tests available and used, but there is limited evidence for specific diagnostic criteria. Infection can be acute or chronic, early or delayed, localized or extensive. In the acute scenario, there can be an overlap between postoperative pain, swelling, redness, and a bit of ooze, and infection that is trying to take its roots. And hence, the buzzword nowadays is a multidisciplinary approach. Here is an example that highlights the complexity of the situation. This is a healthy lady who had a segmental open fracture in 2014. She had initial debridement and X-fix, as you can see with the X-fix pin-side scars. A few days later, at a nearby center, she had fix and flap. All was well for about 4 to 5 years, and this January, she started to jog to improve her fitness. So there was a local flare-up, but she couldn't come to the hospital. Local antibiotics were given in the community, and eventually she came up to the hospital at peak COVID period. The only investigations she had were bloods and X-rays and swabs. We decided to take the implant out with the help of plastic surgeons, 6 weeks of IV antibiotics through a PICC line, and now she is symptom-free and off antibiotics. So the negative feature of this case highlights delayed infections. And the positive feature is that although the scenario could have been potentially worse, her symptoms have been, at least for now, been resolved with a simple intervention of implant removal, local debridement, and antibiotics. Will it recur? Only time will tell. So coming to protocols and guidelines in the UK, there are national guidelines, local guidelines, and some surgeons have individual preferences. As one would expect, BOA, the British Orthopeadic Association, takes a lead role and collaborates with relevant specialties in bringing out guidelines and regularly updates them. I'll go into some of the details. Now, on this screen, there is a sample of open fracture treatment guidelines written in collaboration with the British Plastic Surgeons Association. This next slide is one which has guidelines for peri-implant or fracture-related infections. The content leads from raising awareness, prevention, to measuring outcomes and everything in between. And coming to our own hospital protocols. So there is a trauma SOP for open fractures. There is a adult pocket antimicrobial guide, which goes through antibiotic protocols from UTI to bone infection. And there is a specific antibiotic prophylaxis guide for open fractures. So what happens on the shop floor for open fractures at King's? The service is consultant-led. Plastics are usually physically present during weekdays, but they're always available on WhatsApp. There is no midnight operating unless there is threat to life or limb, limited or no use of tourniquet. The instruments that are used for initial debridement are put aside the limb redraped, and fresh set of instruments are used. Definitive fixation is undertaken only if the wound can be closed safely. Negative pressure dressings are routine, and we use cement spacers or beads for dead space management. Now here's an example which shows a post-debridement picture with an X-fix, a vac dressing. Amongst all, the fracture itself is a simple fracture. What happens next? Because we don't have microsurgery facilities at King's at the present time, the patient goes 5 miles down the road and has a combined definitive orthoplastics procedure with an appropriate implant, and a definitive skin cover is given usually by an ALT, as you can see in the picture. So moving on to protocols. We've already touched upon the lack of scientific and reliable diagnostic tests. And this is a paper that is worth reading. This is a European consensus group article, which goes into the current state of diagnosis of fracture-related infections. So for diagnosis of peri-implant infection, a high index of suspicion is always necessary. This cannot be overemphasized. We tend to overestimate our own luck with not having infections. We have to follow the basics: systemic and local examination of the patient, history, blood tests. In acute phase, blood culture is useful. Otherwise, CRP, ESR, white cell count. Imaging, there is a range of imaging facilities that are available, but plain X-rays should be the start. Now, the paper goes into some detail about the role of white cell count, CRP, and ESR. The summary is that of all the tests available, CRP seems to be the most useful in acute infections, with a specificity ranging from 34 to 86% and a sensitivity ranging from 60 to 100%. Meta-analysis has shown that there is a limited diagnostic value, especially in chronic and delayed situations, for white cell count, CRP, and ESR when done individually. Now, as I said, plain X-rays are still the primary tool to suspect and diagnose infections. There can be lysis around the implants. There can be evidence of fracture instability. There can be profound osteopenia. Serial X-rays are always useful. Now here's the X-ray in the middle, which shows a sequestrum, atrophic non-union. The picture on the left gives a little perspective of the fix and flap day, where the external fixator is removed and the wound being prepared for the ALT flap. The picture on the right shows the current scenario, which has a beautiful ALT flap and a chronic sinus. This patient recently underwent a removal of implant, excision, and bone transport. If with blood tests and imaging, you are not able to reach a diagnosis, bone biopsy is touted as the gold standard. If you have to perform a bone biopsy, you have to follow the following principles: stop all antibiotics for 2 weeks before the procedure, take multiple samples, send a sample for histology, use sterile instruments for harvesting each sample. Now at King's, there is advanced consultation with a microbiologist who has special interest in orthopedic infections. We've seen earlier how to harvest samples. A doctor, usually a house surgeon, sometimes even a consultant, takes the samples themselves to microbiology lab. This happens usually within the first 1 to 2 hours after harvesting. Microscopy results are available on the same day. Standard cultures are available within 48 to 72 hours. Enrichment cultures are available in a further 2 days. Histology is not sent for routinely. So the pitfalls of bone culture is that it has a false negative rate of about 40%. Patient may receive antibiotics in the community. If you have a new anesthetist, they may administer antibiotics at induction. And sometimes, despite you handing over specimen to the lab, they will be sitting in the refrigerator overnight or weekend. To touch upon the microbiology at King's, the most common organisms are much the same as elsewhere, with Staph aureus being the most common species, coagulase positive, coagulase negative, Staph epidermidis. The difficult ones are Enterococcus and Pseudomonas. On a positive note, the MRSA rates seems to be coming down, but there is always the odd multi-drug resistant organism. In summary, peri-implant infections are serious, obviously. However, awareness about the judicious use of antibiotics, use of negative pressure dressings, and using long lines to deliver IV antibiotics has made a positive difference. Complex trauma being managed at specialist centers with plastic support hopefully will lead to ongoing reduction in bone infection rates and better outcomes. In conclusion, I would say that prevention is the key, as cure may not be possible. We have to develop, update, and follow guidelines and use a team approach or an MDT approach. Now, this picture is the only dedicated bone infection unit in the UK. This is in Oxford. And the chap that you see is Martin McNally, who is a regular speaker, and he is published in the Indian Journal of Plastic Surgery as well. And he is part of the contributors to the consensus group that we have seen. Thank you.
Yeah, thank you very much for an excellent presentation. May I now invite Mr. Lahoti to present on management of infection after the fracture fixation. Mr. Lahoti.
Yeah, allow me to share the screen. Yeah.
Yes.
Yeah.
I can't now. Okay, up on. Can you see me?
Yes, you're visible now. Yeah.
Yeah, the screen. Screen is visible. Yeah, presentation.
Yeah, screen is visible.
Okay.
You can go ahead.
Thank you, Naveen, for setting the scene. There will be some repetition where it is appropriate, so please bear with me. Okay, so we both work at King's. So as Dr. Gupta said, it is a very serious problem. It's 100% for the patient, whereas 1 or 30% or whatever you want to call in your series. But what we are seeing is it's probably decreasing by following the guidelines and a bit more awareness, but still a persistent problem. Even in our unit, we have a burden of infection, which is very, very expensive. And I can tell you, no form of operative fixation, whether it's nail, plate, or frame, they all are associated with infection. So, yeah. So this is where my problem is. You know, we come to these conferences and talk about what we do. It is not the same. The disease is the same, but approach is different because there's lot many factors. Like our practice culture is different. We share cases. There are referral units, and there is generally no blame game. Although we might say a few things about the initial management, we generally don't tell the patient that he has done you wrong. And funding is not an issue. You know, I'm aware, acutely aware, the private practice scene in India, whereas here we are state funded. So it seems there's unlimited, or at least you're not limited by funding aspects. And there are severe medical legal aspects. So you can't be a wayward guy sitting out there and doing everything you want to do and deny your own infection rate. That's not going to happen. And of course, we have regulatory institutions like both BOA and all, they keep an eye on us, and we have a governance structure. So what we do is exactly not transferable to Indian practice, but principles are safe. Okay, this talk is not a very scientific talk in terms of number of cases, series, etc. But I can tell you over 20 years of experience that no single approach suits every case, because every case is unique as it can get. So my talk is a mix of science and experience and learning from my own mistakes. And I can tell you this is not the only approach. When I discuss the cases, I'll just show you that was my approach and it worked, but in my hands. So aim of the treatment is same. Eventually you want to get the fracture healed, infection eradicated, have a good soft tissue envelope, a scar that doesn't repeatedly break down, and we want to have a reasonable function. So basically what we are saying is that whether you're in India or in UK or in America, it's the same God we are seeking. But there are many ways of doing it. So it's a team game. Naveen has already laid out who all are involved. But I say patient is also very important team player. You need to really sit down and talk to them seriously. Go through the whole scene. Don't shrink when it comes to saying that, you might be better off having an amputation, particularly lower tibia, foot damaged, and, stiff, painful ankle, chronic pain syndrome. So you need to have a heart-to-heart talk with the patient and take him on board. Don't treat him as, I'm doing my job and that's it. That wouldn't work. And you need to have a group of colleagues. When I say a group, orthopedic colleagues, including a frame surgeon who is keen on doing frames. There's no point in just having platers or nailers who hate frames and don't look at the other sort of big modality of treatment that can be helpful. And microbiologist or infectious disease specialist, plastic surgeon. And here in London, particularly in King's, we have specialist nurses who help us a lot. We have psychiatrists who give guidance to patients. And also recently we started a financial advice clinic. As you can understand, by the time they come to a referral unit, they're completely broke, losing a wife, losing a house, and all that sort of stuff. So I generally use this ICS approach. It is well written up if you want to read up. So there are multiple factors actually leading to the infection. So what you need to keep in mind is the infection early or late? There are different characteristics. I'll show that in a minute. Is it active, like pouring pus, or systemically unwell? That's a completely different ballgame. You want to admit him, you want to give him IV antibiotic. If it is indolent, you might want to wait. Or is it intermittent? Sometimes it's on, sometimes it is off. And the most difficult problem in our game is a non-union, a painful limb, and you're constantly worried, is there a lingering infection? So you're suspected, but you can never confirm, however much you investigate him. And then you want to carefully see, is fracture healing? Is callus present? Or, as Naveen said, repeated x-rays. You have to get them and just see, is callus progressing? Because infection is a double-edged knife. It not only sort of kills bone, but it also kills callus. It also loosens the implant. So you need to then look at the implant, whether the implant is solvable, is it stable, is it fracture anatomically reduced, because anatomical reduction itself gives stability, and look at the stability of the whole construct. So I tend to differentiate between early and late because of the biofilm behavior. Within first 2 to 4 weeks, the biofilm is not so adherent, and you can bust it by giving antibiotic or washing it out. So osteomyelitis is unlikely, but as you progress down the time scale, osteomyelitis becomes likely. So you might be taking the implant out, but you cannot eradicate infection. And if you look at the fracture union in, sort of early stages, fracture union, if you control the infection, is very, very likely. But in late infections, you have to really be more aggressive to get union. So what are the paths? What are these paths I was talking to you about, going to the guard and getting the same aim? So one is mainly a conservative approach, which is irrigation, debridement, retention of implant, and antibiotic suppressive therapy. This is taken from joint replacement approach, where you have to keep the implant, trying to keep the implant. You can't take the joint out and that's it. So DAIR approach has been adopted from joint infections. And the more aggressive form of treatment is you have to take everything out, debride the bone, and remove the implant, maybe exchange the implant, long-term antibiotics, single or multiple stage treatment. We'll see a couple of cases, and I will illustrate this issue. One of the most talking point at these meetings is the type of antibiotic. We need an antibiotic which can penetrate the biofilm and kill the dormant bug. And rifampicin is playing an important role. Again, it should not be used on its own, and it should be used with some other antibiotic. I'll tell you, you really need to talk to the microbiologist about these recent developments and as they move on. But what we can add is the local antibiotic. We used to use gentamicin beads, which would get infected, and you pull them out of a pool of pus. But now we have moved to absorbable activated calcium components, where you can add antibiotic and leave them in place without having to take them out. So IV therapy in acute phase is important, then you can move on to oral. And one thing to remember is if you're retaining the implant, you have to use it longer than if you have removed the implant when it is shorter duration. So debridement, I think, is a very important cornerstone. When I was in training, we used to do the last case, somebody says, go and drain the abscess and take whatever is loose. But that is a wrong approach. As soon as there is infection, the senior-most surgeon should get involved. Do not leave it to the trainee, please. And stop at antibiotics 2 weeks before, if possible, unless the patient is septic. And we talked about all the sampling business. But I'll come down to the last one, this bone and soft tissue debridement. If you look at the literature, they say it should be oncological approach. That means every bit of ugly, dirty-looking soft tissue should come out. It shouldn't be that. You can have a measured approach. You can be very conservative in how much you excise, but be safe. And that comes from experience. And then you decide whether to retain the implant or not. And it is appropriate if it's a closed injury, probably an interarticular fracture with no joint infection. Plates do better than when you retain the implant. And if you have a good soft tissue cover too, they do well. It is not at all appropriate if it was an open fracture with extensive contamination, an intramedullary nail where eradication of infection is not easy even after reaming, if the fixation is unstable, if there's a big hole in the soft tissues, and if it is a resistant bacteria like MRSA, or when the host is very poor, then you cannot retain the implant. So here is the first case. It's a 38-year-old fellow who fell off a ladder. He's a manual labor, sustained a lower tibial with extension into pilon, loss of blisters. So the surgeon who started the treatment put an X6 and then did an open reduction of fibula. So he held it, and then after 2 weeks, he went back and repaired or reconstructed the pilon with multiple plates. And within a week or two, the wound started looking not so good and started breaking down. So here are the X-rays. So the one on the left-hand side is the first X-ray. You can see it's comminuted, high energy injury. The beak is on the medial side. The spike is trying to poke out. And they lined it up, fixed the fibula, and then did what majority of us would do. Lower tibia is showered with plates and screws. But then this happened. As you can see, that's a medial wound. So here is this. It's an early infection, so we can control with antibiotics. And there are lots of implants. And the implant on the medial side, if you poke the wound with a swab or with a probe, you could feel the implant. So that is compromised. So I said, I have this concept of two compartments. For me, this compartment is pristine at the moment. You can see here, there's no flare-up, no infection, no collection. So this is a good compartment. So I needn't go around taking all the implants out here. So just take this implant, clean up the wound, and that's what we asked them to do. This was this case went back to a referral center, and then, as you can see, the fracture has nicely healed. The skin is intact, and then the second stage or the third stage is to get rid of the implant. Once the patient has had an infection, I recommend highly that you get rid of all the implants. Otherwise, they come to haunt you maybe 2, 3, 4 years down the line, like the case shown by Naveen earlier on. So that is my case of debridement and implant retention because the patient is young, limited infection, early infection, 2 compartments, and it's a plate. Now move on to this another case, a 40-year-old involved in a motor vehicle accident, grade 2 open tibia and other injuries. But remember this guy is a smoker and he smoked marijuana. So where he presented, they debrided the wound and put an intramedullary nail. Then he developed delayed infection, which is generally 4 to 6 weeks, let's say. The wound heals first, maybe, and then starts to. So I advised them to get rid of the implant and ream the nail, ream the marrow, and get some deep samples. They did, and it didn't settle down. He had IV antibiotics, and they grew MRSA. So here is the case where you have to be very careful, and you have to be aggressive. There's no point in reaming and renailing these patients because you're not not at all confident, at least I'm not confident I eradicated everything. So here is the sequence. It's a high energy injury, comminuted, butterfly fragments everywhere, nail, not 100% satisfactory, but it's okay. And after removing the nail, I'm sure this piece is dead and that piece is also dead, but that you cannot debride these if you're re-exchanging the nail. Here is the active sinus. So again, we had an MDT, that's what we do. We said exchange nail and antibiotic coated nail is not ideal. We need to really debridement. It should be complete and we have to go back in. And that is likely to create a huge defect, as you will see. And when you have a segmental defect, nail is generally not easy to handle, even with the cement spacers, etc. At least in my hands, that's what I said. It has to be individual treatment. And of course, MRSA means trouble. That is methicillin resistant staph aureus. And he's a smoker. So, and I look at these factors. ICS, there's active infection, there's absolutely no callus, and stability. If you see here, it's ununited. Yeah. So what we decided that no further investigations are necessary. Don't waste your money and time doing lots of scans. You would not get any other more information than what you've already seen. So we repeated deep cultures when we did the biopsy, and because he's not allergic, there's a good range of antibiotics available to us. So I went like this, a thorough debridement. I generally use this hexapart just because I'm lazy and I'm not that clever with the frames, although I went to Kurgan, but there are certain advantages to this. And if you're making an incision on these cases, please do not make a longitudinal or transverse incision, make a Z-plasty incision. There's a nice paper by Professor Hamish Simpson from Edinburgh describing how to plan your incisions in these cases. So I opened it up, it was all nasty, all these pieces came out, and that left us with 3 centimeter loss. And the debate here is whether you do debridement with tourniquet or without tourniquet. I use tourniquet, but I definitely release the tourniquet to make sure that I got a bleeding bone. So that is my way of doing it. And then you'll see here, because it's 3 centimeters, it's easy to, in a controlled way, close this gap. And this is where this frame comes handy. You can wind down the straps and close it on the table while watching the circulation on the foot by an oximetry. So I close the wound, and that is reasonably good closure, no tension on the wound. And then we started a bifocal treatment because the docking site in the proximal tibia, there was no way of lengthening him from there. So we started a distal osteotomy and lengthened him from there. And at 5 years, you will see the follow-up. There's no recurrence and you've got good function. So here is the follow-up. I just wanted to show this one here. So this is where we lengthened him from. It is too close to be doing lengthening from here. And when you do a lengthening process from here, it is a very slow process. I don't lengthen them 1 millimeter, I do 0.5 millimeter, and I docked it there. Because we were dealing with dissimilar diameters, a narrow bone here and a wide bone here, you're bound to have a step. You can work out whether you want to dock it in the front or back. So this is his function, good knee flexion, and this is 5 years plus. I did him in 2014, and I saw him end of last year, and he's still doing well. So there are a range of presentations and range of problems, and you have to tailor-make the treatment. You can differentiate between 2 weeks and up to 4 to 6, 10 weeks, whatever your criteria is. That is a watershed and a line, and you can differentiate between to keep the implant or not to keep. And that's my approach to it. Thank you.
Thank you very much for a wonderful presentation. Indeed, 2 nice cases to see, one with implant retention and one with bone reconstruction. So let us present our own experience and take your opinion on it. So may I invite Dr. Rajesh Goel to present a case, please. Or is it Akshat who is presenting? I don't know. First case, if you can go for screen share, he has already exited his screen. Just allow it.
Okay, well, any questions have come through? Well,
yeah, so far nothing on my screen as far as questions go. I don't know how many people are watching it live because that I can't do while in the session.
Yeah,
with
no,
you.
that's fine. Okay.
Yeah.
So, but while waiting for the cases to come out,
Yeah,
I
of
think we
course,
can
of
have
course.
some
That's what
discussion.
I thought. I checked the chat box, there is none. Right, okay. We started the screen share. So, if you can go to
good
the
afternoon,
PPT,
friends. Good afternoon, friends. I'm sharing my case. He is a 30-year-old media person. He sustained injury while covering a cylinder blast fracture, and then he sustained compound fracture leg bones.
can I interrupt you there, Dr. Goyal? We are unable to see your case. So, you'll have to run the PPT on the screen, please.
Okay, okay.
You just double click it. You already ticked it. You just double click and put in presentation, please. Open the file. It is on your desktop. I can see it ticked.
Double click. Is it okay?
No, not yet. You need to open the screen. Open the file and put it on presentation mode, please.
Yes.
Can you see me now? Can you see the presentation?
Yeah.
Okay.
Yeah.
Okay. So here you go. Go ahead.
Yeah.
Now you can talk.
Yeah. So this young fellow sustained injury, compound fracture 3B type, Gustula Anderson. It was a gas blast season explosion which led to this outcome.
So you described that this is the presentation, right? Okay, go ahead.
Yeah. So we did. This is the pre-op X-ray, and this is the pre-op slide, which is showing the wound over the lower third of the leg bone on the left side. Next slide, please.
Okay. So this is what you did, yeah.
Next slide, please. Yeah, so this is how we did. We went for IV antibiotics. He was shifted to the OT. Then we did debridement with removal of the metal particles, and we had 6 liters of saline wash. Then the draping was changed and its fixation was done with unreamed interlocking nail with 30 size and intramedullary rush nail for the fibula. Again, saline lavage was done with wax applied over the wound, and abdominal slab was given. And
so this was the appearance post-operatively. So you are a patient in a slab and a nail in situ. Yes, sir. Go ahead, please, Dr. Goyal. Oh, he probably. Well, anyway, what happened is that after having a repeat ESR CRP, they did a re-debridement that was planned, and the wax was removed and a secondary closure was done. We are seeing the wound here after the secondary closure, and they continued the IV antibiotics for another 7 days. Dr. Goyal, are you here? Yeah, go ahead, please.
Then the patient was discharged on the 14th post-operative day, and the oral antibiotics were continued for next 7 days. Sutures were removed after 15 days, and above knee slab was continued for another 1 month. Next slide, please. Next slide, please. Then the slab was removed after 1 month from the second surgery, and this is the X-ray of that after fixation. Next slide, please. Next slide, please. So this is the final follow-up after two years and 4 months. This, please, one slide previous. This is the final follow-up after 2 years and 4 months. This is the fracture has united. This is the previous follow-up in which the nail was there, but the bone showing the union. So then the sinuses were healed completely. So we had the removal of the nail. Next slide, please. Next slide. So this is the after removal of the nail, and this is showing around a good union. This is the final function of the patient. Next slide, please. The video. Yes, the video. Next. This is the.
Well, these are the papers you are referring. Let me stop you there and ask Mr. Lahoti whether any comments on what has been done so far, or.
No, I think wonderful management, and that's what you do. That's what you are happy with. We probably would have done it slightly differently. I would have probably erred on a circular fixator and compressed the fracture site, but there are many ways, that worked for him. But it is a high-risk strategy in my view. Nailing these sort of open fractures is good, but when they start getting infected, that's when I start to worry. But you got away nicely there. Well done.
Okay. So let's discuss very briefly the case 2, and we'll conclude the meeting. So go ahead, Dr. Goel, please.
I think it is. We are overshooting the time. I think it's
we are
overshooting
the time.
Well, you can continue because Dr. Goel, you can run through the case quickly because hall is still continuing. So you can.
Okay, fair enough.
Okay.
Yeah, because I'm watching hall here also.
So this is another lady, 54-year-old lady. She sustained injury on 21st of November. She developed proximal tibia and fibula fracture left side. She had gross swelling, so we kept her on wrong splint until the wrinkle sign developed. Next slide, please. Next slide. So that after 14 days, we fixed her with the lateral head buttress plate, and one screw was with the tibial spine avulsion. Then next slide. So this is the fixation after that. Yeah. Then next. So, but then suddenly she started oozing. There was oozing from the wound site. So we planned that the implant should be removed, and we removed the implant. We did thorough debridement with saline, betadine, hydrogen peroxide, and lavage was done. And then
1 month post second surgery. Yes, Dr. Goel. So I think I'm unable to hear him. So there were no signs of infection left, and the markers were normal. The patient was not able to full weight bear and couldn't walk with support. So the fixator was removed and above knee cast was applied for a month. So this was the presentation at 3 months, where no clinical signs of infection are left. We don't have a tenderness at fracture site. And they started mobilizing this patient, and the patient was able to full weight bear with support. And that's the current clinical picture. Patient has a well-healed scar, a good range of functional movement at knee, and is able to weight bear and carry out day-to-day activities. And that's the gait they have recorded, but somehow it won't play. So can I ask Dr. Abhishek, Mr. Abhishek, any comments from your side on this particular case, please?
Tibial plateau fractures have divide people into 2 halves, really. When you have fractures that are of low energy injury and predominantly extraarticular, it's fantastic to treat with internal fixation devices. But when you have anything more than a low energy injury, frame in our hands gives a much better outcome because there is limited fixation, low profile fixation, just 2 HA coated half pins for the distal ring, a couple of wires, and maybe a HA coated half pin for the proximal ring with a 3/4 ring at the top. So people are able to flex to 90 degrees and walk fairly straight away within 2 to 3 weeks. Plating.
Sure. If I can ask you about fixators, I mean, I'm sure you must have been exposed in India about Joshi's external fixator system, which was developed and was used for hands predominantly, but you know, we have used it in fixation of fractures of proximal, interarticular fractures of proximal tibia as well. Do you have such kind of low profile fixators in your usage in London?
I mean, there are two different types of fixators, hexapods we have in our unit. One is the Smith & Nephew one, and the other one is the Synthes one. And you know, there is a difference in principle when you want to manipulate the fracture, but they're both fairly low profile and well tolerated. I think it depends upon the experience of the user.
Yes.
The more experienced you are, the better you are at constructing these.
Yeah. Okay. So the take-home message from this talk, I mean, the cases presented here is that intramedullary fixation can be extended early debridement is, I mean, they're all basically reinforcing the same thing. We are using more of cement beads here, but we do have absorbable antibiotic delivery system available. Cost is an issue for patients coming from poor economic backgrounds. So sometimes, you know, we can just use local vancomycin powder and, you know, keep our fingers crossed. But again, sustained antibiotic local delivery is what is important when you are tackling this kind of infection. I really appreciate and thank you for all the input from esteemed faculty. Jayant, would you like to say something on behalf of Rosa?
Yeah, so I think I would especially like to thank Dr. Lahoti and Dr. Abhishetty for joining us and being there and putting in all your efforts for this meeting. Dr. Goyal, thank you. And we are missing Mr. Anand Arya. I think he was instrumental in organizing this meeting. And I wish him well. I don't know why he couldn't join us, but I hope all is well at his end. Thank you, Dr. Solanki, for moderating this session. And
yeah,
you can stop sharing.
Thank you, Dr. Sharma, Dr. Gupta, for sharing the session and encouraging.
Thank you. Thank you very much.
Thank you to the chairpersons and Dr. Mahesh Gupta and Dr. Sharma for all your good wishes.
Thank you very much.
Thank you, guys. Thank you.
Okay. Bye-bye.
Bye-bye.
Mr. Solanki, can you stop sharing your screen?
Yeah, I'll do that. Just a moment.
So, I think we'll leave for now and request all the executive to reassemble for the valedictory. It has been a very exciting day for us. I think we set a certain level of milestone. So Dr. Goyal and Rahul and Dr. Solanki, they've been really involved in all this. So, and of course the audio-visual team of Vision Plus. So I think we just leave from here and we meet in the new.
And we meet in the hall. Okay. Thank you, everyone.
Okay. Thank you. Bye-bye.
Okay. Thank you. Bye-bye.
Bye-bye.